My name is Ninez Ponce, and I am the director of the UCLA Center for Health Policy Research. This session is being recorded. As a land-grant institution, we would first like to acknowledge the Gabrielino Tongva peoples as traditional land caretakers of Tovaangar, that is the Los Angeles Basin and South Channel Islands. Thank you so much for being with us here today. It is one of my favorite days of the year, the California Health Interview Survey annual data release. If this is your first time joining us, welcome. To those of you who have joined us for many years, thank you for your continued support. The California Health Interview Survey, which you will hear us refer to as CHIS, is the nation's largest population-based state health survey. It's used by legislators, by other policymakers, by local health departments, state agencies, community organizations, foundations, researchers, advocates, media, and many more. CHIS provides actionable data on the health and healthcare needs of California's diverse population. Over the last decade, the California Health Interview Survey has played a critical role in identifying health issues and inequities and shaping health policies. It also helps shape interventions and programs that improve the lives of Californians and people across the nation. During the next hour, we will be discussing some of the key findings of the 2022 California Health Interview Survey, from food insecurity, hate incidents, and ongoing mental health concerns, to new ways of accessing care and barriers that are preventing people from getting the care they need. So there's a lot to cover in this next hour. My colleague and our California Health Interview Survey Director, Todd Hughes, will walk through some of those findings, and Senior Public Administration Analyst Sean Tan will discuss a fact sheet released this morning that looks at telehealth usage among Californians. But first, I want to note to everyone that, as always, today's webinar is being recorded and will be posted to our YouTube channel in the coming weeks. If you would like a copy of today's slides, please email us at our communications department at healthpolicy@ucla.edu, shown here on the slide. I'd also like to share information about an upcoming event. While today is about sharing highlights from the CHIS, on Wednesday, October 25th, we will show you how to access and use CHIS data. Join us for a special data user training where you will learn how to use CHIS's free online data tools, including Ask CHIS, Ask CHIS Neighborhood Edition, and the CHIS Preliminary COVID-19 Estimates Dashboard. Our communications director will be putting the registration link in the chat. We have several CHIS staff here today, monitoring and responding to some audience questions. We will reserve the last 15 minutes of the webinar for the Q&A. And we encourage you to ask questions throughout the presentation using the Q&A function and Zoom. Again, thank you for coming and joining us today. So let's get started. So what is the California Health Interview Survey? As I've said, it is the nation's largest state health survey, largest state population-based survey. It is deemed as the most comprehensive source of health information on Californians because we ask about a range of health topics, as you can see here, on health status, conditions, mental health, access to use and health services, health insurance, which is actually the foundation of the California Health Interview Survey in its inception. And CHIS is a collaborative project funded by federal and state health agencies in California, as well as national foundations and many, many others. A report of the 2022 CHIS impact looks at our impact on access to data tools. So the biggest number here is the 90,000, over 90,000 queries in our free Ask CHIS and Ask CHIS Neighborhood Edition tools. Legislation and advocacy have used the CHIS data. We've had several seminars like today, events and presentations. We've had almost 100 publications just in the past year, journal articles and publications that were produced by researchers, which I'm sure some of you are in the audience right now. And we thank the media for covering stories that use CHIS. We've had 300 plus media hits over the past year, many of which feature the CHIS data in their stories. So thank you. The CHIS design, for some of you who wonder how this is done, and I know that some of you out there may have been in our sample and perhaps received a $2 bill, but we interview or get information on all ages. So there is a sample child that is interviewed after we screen the household. The child's information is provided by a parent. Then we do a sample adult interview, who then, if there is a eligible adolescent in the household that's also randomly selected, that there are more than one adolescents, that the parent then would give permission to interview or to have the adolescent provide information to the California Health Interview Survey. I'm really proud to say that CHIS continues to ensure that we don't have what's called coverage bias by, say, just having the survey in one language, say just in English. We have been conducting the survey in many languages that are spoken in California. So English, Spanish, Chinese, both Cantonese and Mandarin dialects, as well as Korean, Vietnamese, and Tagalog. CHIS had a redesign for, many years. Just was a telephone survey, landline, then we started including cell phones and mostly cell phones, but we made a switch. In 2022, the data collection method reflects the switch that we did in 2019, where it's called address-based sampling with web and telephone response. And the infographics here summarize the process of our household selection. There are 4 mailings. They're spaced every 2 weeks to an address that's been sampled. We ask one of the randomly sampled adult to respond, and we push them to go online, to go to have a URL, and they can fill out the survey. If that is not feasible, if that is not preferable, or there might be other barriers in doing an online survey, they do have a telephone number that they can call to complete the survey by phone. And this is absolutely important, particularly for those who don't have a computer, who may not have enough bandwidth, who may be linguistically challenged in looking at the directions. Although we do, when we do the mailing in several languages, the languages that I had mentioned in the previous slide. If we don't hear from the respondent via the web or by phone, then we do start to have a call center staff call, and this is what's called the conversion, to try to get the non-responses to convert and participate in the survey. But we don't want to bug them, infinitely. So we do we do call back up to 6 times. We do try our best to reflect California's diversity. So CHIS is done by, we have targeted sampling methods for some populations in California. For example, we do a Korean Vietnamese oversample that focuses on areas where a large Korean and Vietnamese population, and where Korean and Vietnamese is spoken. So that's an example. We have some other examples. We do multi-mode data collection, as I had just described, where it's the respondent has an option to finish the survey on the web, or to complete the survey by telephone. We have language support. We also do some custom oversamples. Say a county may want to oversample a particular racial and ethnic group. And then we also have opportunities to use a CHIS sample as a way to recruit for follow-on studies where there may be some specific questions, for example, looking at long-term services and supports in the workforce there. Our 2022 data collection highlights by race and ethnicity and by age are featured here in this slide. The total adult sample is 21,463, the adolescent sample 985, and our child sample 3,395. By race ethnicity, we have the breakdowns here for African American, American Indian Alaska Native, Asian, Native Hawaiian, and Pacific Islander, white, other single race, 2 or more races, and then by the Latino ethnicity, categories by Latino and non-Latino. And this is per the OMB minimum standards for collection of race and ethnicity. If some of you have used CHIS, you will know that we go even more granular in the racial categories. And for the American Indian Alaska Native, there's more granularity in tribal affiliation and tribal enrollment. The supplemental sampling methods for CHIS have been really important in ensuring that we have representation for populations that we really have to try harder to reach. So one I think successful example is the prepaid cell phone sample. We targeted, I think 500, but we got 450 completes. The objective was to increase, as I said, representation, particularly for those young adults age 18 to 24, the Hispanic Latinx population, Black or African American population, and Californians who prefer to take the survey in one of the non-English languages. This was a new component, which we had done it last year, that was where the yield on these groups, as I said, that we have to try harder to reach, was successful. Other targeted oversamples are by geography. So we have San Diego County oversamples, also by health system area, Martin Luther King Community Health oversample. Martin Luther King Community Health is in Los Angeles, in South Los Angeles, an oversample of 400 adults in 13 zip codes in the LA County service planning areas of 6, 7, and 8. This may mean nothing to those who don't live in LA County, but I'm sure for those who focus on health improvements in LA County, that they'll be happy to hear about this oversample. We also oversampled for the American Indian Alaska Native population in rural areas, which yielded an additional 125 adults. We also worked with Santa Clara County to devise an oversample of nearly 2,000 adults for their county. So 10 million. So there's actually, I'm going to start there with the 10 million. There are 10 million different CHIS estimates that can be explored in our free web query system as CHIS. This 10 million queries are a product of the 391 or so variables and topics that you can type in and say, I want to learn about asthma, for example, and then you can compare it by race and ethnicity. You can compare it by educational status, by geography. So several stratifications that you can compare, cross tabulations that you can instruct as CHIS, which on the fly will present to you these estimates. And you can examine these for 66 different geographic areas in California. If you want to explore more, or you're comfortable in conducting statistical analysis on a data file, we have a public use file, and this public use file contains This is actually 2022, contains 1346 detailed variables for research. So what's noteworthy to CHIS 2022 is that we ask about experience of hate incidents among all adults in California. We also continue to monitor vaccination status and information sources related to COVID-19. We have expanded the questions on COVID-19 to adolescents and children, asking questions about vaccination status. And all of this, because it is information that the public wants, is available in public use files and through, again, our web query system, Ask CHIS. So I'm going to turn this over to my colleague, Todd Hughes, who is the director of CHIS.
Thank you very much, Ninez. All right, it's my great pleasure to share with you some of the findings from the 2022 CHIS. And as Ninez mentioned, with over 391 topics or indicators and over 10 million different CHIS estimates produced for 2022, I can only provide a small glimpse here of what we can learn from today's data release. But since its inception in 2001, one of the key objectives of the CHIS has been to measure and understand health insurance coverage in California. And we're pleased to report that in 2022, we have measured another record high rate of health insurance coverage for all adults, adolescents, and children in California, rising to 94.8% in 2022, a statistically significant increase from 2021. Next, looking at health insurance coverage for adults by race and ethnicity, we see that these gains were not equal among all groups. The group with the largest statistically significant increase in coverage was the Latinx group, increasing from 86% insured in 2021 to 89.4% insured in 2022. For all other groups, none of the changes between 2021 and 2022 were statistically significant. In addition to increased insurance coverage, we're also seeing increased access to medical and dental care in 2022. Rates of adults who stated in 2022 that they visited a medical doctor in the previous 12 months recovered to a large extent from pandemic lows, significantly rising from 76.6% in 2021 to 80.9% in 2022. But this is still below the 2019 rate of 82.4%. We saw an even larger increase in adults that reported seeing a dentist in the previous 6 months. This fully rebounded from pandemic lows of 45.3% in 2020 and 50.7% in 2021 to 55.6% in 2022, exceeding the 2019 rate as well. Unfortunately, this rise in utilization of medical and dental services was accompanied by increases in difficulties finding a doctor or getting an appointment. 2022 showed a large increase of those who were not able to get an appointment within 2 days for those who needed one, rising to 22.4%, higher than the rate seen before the pandemic or during the pandemic. Similarly, the rate of adults who were not accepted as a new patient by a doctor in the past year rose to 6.1% in 2022, a statistically significantly higher rate than 2019, 2020, or 2021. This concerning trend continues across 2 other access to care measures. The rate of those who had trouble finding a general doctor who would see them in the past 12 months was 7.5%. And the rate of those who had trouble finding a specialist who would see them in the past 12 months was 15.8%. And both of these rates are statistically significantly higher than corresponding measures in 2019, 2020, or 2021. Unfortunately, we see a similar pattern when examining access to mental health care. More adults are seeking care in 2022 than in previous years, but they are also having more difficulty accessing that care. The rate of adults seeking help for mental, emotional, alcohol, or drug-related problems from a primary care physician rose to 11.7% in 2022 and 14.5% in 2022 for those who saw a counselor, psychiatrist, or social worker for these problems. These rates are higher than the levels observed since 2019, both before and during the pandemic. However, difficulty getting an appointment was a barrier to receiving care in 2022, since 33.3% of those who felt they needed treatment but did not receive it cited difficulty getting an appointment as the reason why they did not get the care. This rate is a substantial and significant increase from the rates observed in 2019, 2020, or 2021. Now let's examine in these next slides the evidence for the increasing need for mental health care. Last year, we reported how the CHIS identified rising rates in 2021 for two key mental health measures: experiencing serious psychological distress in the past year and ever experiencing suicide ideation. Unfortunately, the 2022 rates are similar to 2021 and are still significantly higher than in 2019 and 2020, with 16.4% experiencing serious psychological distress in the past year and 18.9% reporting that they had ever experienced suicide ideation. A similar pattern was also observed in the 2022 rates for those who reported needing help for emotional, mental health, alcohol, or drug-related problems in the past year, and severe social life impairment due to emotions in the past 12 months at 25.4% and 13% respectively. Both of these rates are similar to 2021 levels and remain statistically significantly higher than the 2019 and 2020 rates. Next, we explored differences among demographic groups that experienced mental health challenges in 2022, specifically for the measure of experiencing serious psychological distress in the past year. Only one race or ethnicity had a rate that was statistically significantly higher than the rate for all adults in California, and that was for Latinx adults with a rate of 18.9% versus 16.4% for all adults. We also examined income groups and found that lower income adults earning less than 3 times the federal poverty level had a significantly higher rate than the general population, with 20% experiencing serious psychological distress in the past year. One other group that had substantial mental health disparities in 2022 was the LGBT population. LGBT adults experienced rates of serious psychological distress in the past year at much higher rates than the state adult average. Gay, lesbian, or homosexual adults had a rate of 29.7%, bisexual adults at 46.9%, and transgender or gender non-conforming adults at 61.6%. These rates are roughly 2, 3, and 4 times the state average respectively, and highlight the mental health care needs of these groups. Next, let's change to examining the issue of food security, especially relevant given the high inflation experienced in 2021 and 2022. The CHIS asks adults earning less than 2 times the federal poverty level about this topic and has measured a rising trend from 2020 through 2022 that more adults are not able to afford enough food or are currently receiving food stamps. In 2022, 44% of adults under 200% of the federal poverty level reported being food insecure or not being able to afford enough food, a statistically significant increase from the 2020 and 2021 rates of 35.8% and 39% respectively. Similarly, increasing numbers of adults in this income range are currently receiving food stamps, 34.5% in 2022, significantly higher than the rate of 28.5% in 2020. When we examine this further by age group, we find that statistically significant increases occurred among working age adults, those in age groups 18 to 24, 25 to 39, and 40 to 64, all had higher rates in 2022 versus 2020. And the age group 25 to 29 also had a significant increase compared to 2021. These working age adults earning less than 200% of the poverty level each had rates of food insecurity near 50% and had increases of nearly 10 percentage points versus 2020. Older adults aged 65 to 79 and 80 plus did not have a statistically significant change in 2022 versus the two previous years. Finally, examining food insecurity by race and ethnicity, again for adults earning less than twice the federal poverty level, we see that the Latinx and white groups were the two groups for which we measured a statistically significant increase from 2020 and 2021, rising to 47% and 38.6% respectively, with a percentage increase of 25.7% and 27.4% over the 2020 rates. The data presented for the other race groups do not reflect statistically significant changes versus the previous year. Next, we'd like to share some CHIS data on a difficult and sensitive topic, physical or sexual violence by an intimate partner in the past year. In 2022, statewide, we identified that 2.6% of adults reported experiencing intimate partner violence in the past year. But there were definite differences by income and by race. Adults with incomes below the federal poverty level were more likely to experience this than higher income adults over 3 times the FPL. 3.6% versus 2.0% respectively. White and Asian adults experienced intimate partner violence at lower rates, 2.0% and 1.5% respectively, than Black and Latinx adults. Black adults had the highest rates at 4%, twice the rate of white adults. 3.2% of Latinx adults experienced this, twice the rate of Asian adults. Next, we look at what we can learn from the 2022 survey on the subject of COVID-19 vaccination. A timely topic is the latest iteration of the COVID-19 vaccines for this season have recently become available to all Californians. Looking specifically at rates of those who have not been fully or partially vaccinated, 11.9% of all Californians age 5 and older were not fully or partially vaccinated. But we see variations across income and poverty levels by insurance status and by education level. Among those age 5 and older, individuals in households below 100% of the federal poverty level had the highest rates of not being fully or partially vaccinated at 21.1%, compared to only 8.6% of those at 3 times the FPL or higher. We also note that those uninsured were unvaccinated at higher rates, 16.9%. Compared to 11.6% of those currently insured. Also looking at just the adults, there was a large difference in vaccination rates by education level, with 15% of those having a high school diploma or less being unvaccinated, compared to 4.9% of those with a bachelor's degree, and 2.5% of those with some graduate level education or higher. Additionally, statistically significant differences were observed when comparing rates of those not fully or partially vaccinated among those age 5 and older by citizenship status and location of residence. US-born citizens were found to have the highest rates of being not fully or partially vaccinated at 13.8%, compared to 9.8% of non-citizens and 4.9% of naturalized citizens. Those living in rural areas were also found to have much higher rates of not being fully or partially vaccinated, 21.5%, compared to 10.9% of those living in urban areas. Finally, we explored how past experiences of unfair treatment in a healthcare setting due to race or ethnicity might impact adults' decisions to be vaccinated. We found a statistically significant difference in the rate of those not fully or partially vaccinated. Among those who have experienced unfair treatment due to race or ethnicity getting medical care, more than 1 in 10, or 13.2%, were not fully or partially vaccinated, compared to 1 in 12, or 8.7%, of those who had never experienced unfair treatment due to race or ethnicity in a healthcare setting. Next, we'd like to share some survey results about those who have ever been a victim of a hate crime or incident. Overall, 11.7% of all California adults report ever being a victim of a hate crime or incident. But white, non-Latinx adults experience the lowest rate among races and ethnicities at 6.3%. The highest rate was for non-Latinx Blacks or African Americans at 26.2%, followed by two or more races at 17.4%, Asians at 15.6%, and Latinx at 13.5%. Unfortunately, we did not have sufficient data to produce statistically stable estimates yet for the AIAN and NHPI groups. However, we do observe some interesting changes in the relative rates by race and ethnicity when we look at more recent experiences. Specifically, when we asked those who had ever experienced a hate crime or incident if they had experienced it during the years 2020 and through 2022, we saw that Asians had the highest rate, with 52.7% reporting the incident occurred since 2020, followed closely by two or more races, Black or African American, Latinx, and all California adults. White adults reported the lowest percentage of incidents occurring since 2020 at 33.7%. And now it is my pleasure to introduce Sean Tan, Senior Public Administration Analyst on the CHIS team, who will share findings from his fact sheet that is being released today titled Telehealth and the Future of Healthcare Access in California. Sean.
Thank you so much, Todd, and thank you everyone for attending today's data release. Today, I have the pleasure of presenting the latest publication on the state of telehealth in California, which uses the newly released 2022 CHIS data. A webpage link is available in the chat if you want to view the publication, as well as its accompanying infographics. Due to the COVID-19 pandemic restrictions, healthcare providers had to reevaluate their healthcare delivery models, which included telehealth. This led to a surge in telehealth use. In 2022, we see that 46.7% of adults used telehealth in the past year, which is slightly less than the 49% in 2021, but is nearly quadruple the percentage, which is at 12.4% of adults who use telehealth in 2018. We examined telehealth use by various social-demographic factors. California adults who use telehealth by insurance status shows that those with insurance reported 48.4% of using telehealth, which is twice the percentage of those who are uninsured adults, which is at 21%. By age group, we see that young adults aged 18 to 26 had significantly lower use of telehealth at 35.8% compared to those above the age of 27. We see that adults age 65 and over had the highest use of telehealth at 54.5% in 2022. Among rural and urban areas, we see that 41.2% of adults in rural areas had reported using telehealth, which is significantly lower than those living in urban areas at 47.3%. We also examined telehealth use by language spoken at home. We see that English adults who only spoke English in the household had the highest at 51.2%. Those who spoke only Vietnamese, 33% had reported using telehealth. Amongst those who only spoke Chinese in the home, 38.3% had reported using telehealth, and those who spoke only Spanish at home reported 38.5% reported using telehealth in the past year. Among those who spoke English and Spanish, 39.9% reported using telehealth, and 42.9% reported using telehealth among those who spoke both English and Chinese. Telehealth among racial or ethnic groups, we see that Latinx and Asian adults were reported significantly lower rates of using telehealth when it's compared to white adults. We see that Latinx adults, 41.5% had reported using telehealth in the past year. And for Asian, non-Latinx, 44.2% reported using telehealth in the past year. When using telehealth, among adults who use telehealth, the top 5 reasons for using telehealth were 1, follow-ups and access to test results, 2, flu, cold, allergies, or infections, 3, joint, back, or muscle problems, 4 is mental health or emotional health, and 5 is chronic disease care or management. Overall, we see in CHIS 2022 that a majority of adults, that is 1 in 2 or 52% of adults who access telehealth via either phone or video, reported that their overall telehealth care experience was about the same compared with an in-person visit. In all, CHIS data shows an increase in telehealth reported telehealth use in 2021 and 2022 when compared to 2018 or before the pandemic. But gaps in telehealth access still exist when examining by socio-demographic categories, and California policymakers will need to focus on creating policies that aims to provide equitable access in order to maximize the potential of telehealth and closing the gaps in quality and access to care across various populations, especially those who have the least amount of access already. Now I'll turn it over to Dr. Ponce for the following presentation.
Thank you. Thank you so much, Sean. And also thank you to Todd for going over. Those are key findings, but there's a lot more insights that can be had by exploring the CHIS data. So how do you get CHIS data? Well, let's talk about our dissemination aims. First and foremost, we protect respondent confidentiality. So we assure the respondent that the responses will be presented more in an aggregate fashion. There are no individual information that can disclose or that improves to have high disclosure risk for a respondent. So that's first and foremost. So for those of you who have responded to the survey, that's our number one concern here and number one criteria. But we also want to balance that with democratizing access to data. We don't want this data to just sit on the shelf and not be used. And so our role has been, I think, the guiding force when we first put CHIS out in 2001 through the vision of Rick Brown, the founding CHIS director and founding center director, is to put data in the hands of those who can use it. We want to make sure that the data is not just for those who understand statistical programs or have knowledge about, scraping data and finding data, combining data, but so that the data is available to reach a large and diverse audience across diverse divides of technology, of skills, and resources. So this box here of different colors shows the kind of multi-dimensional ways that we can access CHIS data, that we provide this for you as the user. On the top, there's a purple rectangle, the Data Access Center. So the Data Access Center, or the DAC, is a center that is sort of the gateway to getting at secure network that holds data analysis and protecting confidentiality, the gateway of asking for restricted data that may not be in the public use files. It might be restricted because there might be some disclosure risk elements, for example, address or location of the respondent, but it also might be restricted because it might, you might want data that's very sensitive and so that we don't release in our public use files. So the Data Access Center is a good place to stop, and we can put, I think Andrew who's on can put what the information on the email on making queries on the Data Access Center. We, in our new website, so thanks to the comms team and the IT team, you can download on the spot the 1-year public use files. And so it's free to download through several statistical programs, SAS, SPSS, and Stata. I think also R. If not R, we'll help you download in R. We also have, if you don't want to use the public use files or the restricted data and doing your own statistical analysis, we have the web query systems. We have Ask CHIS, which I spoke a lot about in the beginning. It is it's an award-winning online health data query tool. It was a Health Data All-Star in 2013. We have also provided technical assistance to other data systems on how to kind of mimic the ease and the comprehensive data displays of Ask CHIS. So I welcome you to try that. I think on the chat there was a question that was answered about getting data beyond the county level on Ask CHIS. And we do have another tool called Ask CHIS Neighborhood Edition. It premiered in 2014. It was really sort of Ask CHIS's little sister, but it got a lot of traffic. There was a lot of demand because as those of us in public health know that health happens in your neighborhood, health happens in more local levels. And so Ask CHIS Neighborhood Edition was really a welcome tool. We also through funding and support from the School of Public Health, Fielding School of Public Health, we have Ask CHIS Neighborhood Edition in Espanol. It's granular health data beyond counties. I'll actually show you a screenshot in my subsequent slides. It is modeled estimates. They're not what we call direct estimates. They're modeled because we would have to do a census, basically of California, to get at the granularity at the neighborhood level. And I can talk about that more when I show you that screenshot. And then there are some users who say, I don't want to use these tools, or I have to go to a city council meeting, or I need to go meet with the stakeholders for my project right now. And, you know, I want a PDF. I want something I can download without having to do all these query systems or do any data analysis. And so we also have a product called Health Profiles that reports on CHIS's most requested health topics, easy to download. You have it ready. We have in all of this data user support and health data capacity building, which I will describe next in the next few slides. So the geographic sample design to produce direct estimates is noted here. The impetus of having a California health interview survey was that we really needed more than just state estimates, but local estimates. Many of the, the national, federal surveys just did not have the granularity to get at the 58 counties in California. And then within those 58 counties, for example, Los Angeles, which has 10 million people, that there are geographies within LA that we need insights on. So our strata, or just the different buckets that we have in doing our random sample, not 58, it's 56. And it's 56 because we group the smallest counties. So there are 17 smallest counties. So there's like a 3-group county strata. And then the very large counties like Los Angeles and San Diego, we actually then have sub-county strata. In Los Angeles, there's 8 service planning areas that we treat as again, like one of those sampling strata buckets that we do our random draws. in doing our probability-based sample. And in San Diego, there are 6 health regions. And the remaining 39 counties have their own individual strata, of course, but no substrata. No substrate estimates unless you work with us in any special analysis, or if you can go to CHIS Neighborhood Edition, for example, to look at estimates within your county stratum. And then there's lower levels of geography require 2 years of data to produce these modeled estimates. And so let's take a look here. Across geographies, we cover the state, of course. So we have state estimates, and Todd Hughes showed you estimates that were for at the California population level. But we also can produce estimates at the county level, with the caveats that the smallest counties are in these 3 county groups, and in the 2 large counties, you can actually even drill down more. Then we can actually get at political jurisdictions at the assembly level, the Senate level, and at the congressional level. But this is from our modeled estimates from CHIS Neighborhood Edition. And we can get at cities and then at zip codes and then as low as census tracts. So when I said modeled estimates, it's what's public facing. You can actually get direct estimates up to the census tract level. There's some researchers that say, for example, combine census tract level data from the American Community Survey with the CHIS data set. And then so our data access center, we can link that. So all of this, since we get an address base, our sampling is address base, we can get as granular as the census tract level. But what is public facing, though, then will differ whether it's a direct estimates or an indirect estimates. So let me try to explain that here. Oh, I think there was a question about the 2-year data. When's it going to be available? That was answered, but it's answered here again in this slide that in addition to 1-year data, we have 2-year data because estimates for some population groups may require, for more stability, statistical stability, may require 2 years of data versus 1 year of data. So the 2-year data is going to be released in the coming summer 2024. CHIS went live, I believe, this morning at 9 a.m. with the 2022 CHIS data. So some of you may have already been exploring it. And for those of you who are new to CHIS, a new user, I invite you to explore it. The census tract estimates in CHIS Neighborhood Edition, these are the modeled estimates, and the lowest geographical level is census tract. When we first launched CHIS Neighborhood Edition, the lowest geography was at the zip code, specifically the zip code tabulation area or ZICTA level. But again, through support and more funding, we were and we listened to users that users wanted at the tract level. So we have CHIS Neighborhood Edition with the lowest geography at the census tract level. And then to the right here is just kind of the visual display of if you choose, say, diabetes or needed help for mental health outcomes. Like let's focus on needed help for mental health outcomes. You can get estimates there at least 5 groupings, geographical areas. So you can look at the state estimate for needed help for mental health problems for adults age 18 and older. You can get, if you live in Stockton, you can get what the estimate is for Stockton. And then you may also want to get at San Joaquin County tract level, so you get tract level estimates. And in this way, then it gets summarized in a comparative bar chart here. We also may want to know if you live in San Joaquin County tract that you want to look at what the composition is of the population by income, by federal poverty level, by race and ethnicity, by gender. And so here we have then some additional visualization of the population that hopefully will, be informative for the user. So all of this, of course, requires some training, and we have an on-demand learning center to accompany our data tools. They can be as brief, you just want to understand one feature, like for example, how do you chart and how do you transpose a bar chart? How do you transpose your query? So they're brief, they're 10-minute segments, so they're on demand. They're simple, hopefully, designed for those who have no experience or those who want to brush up on their skills. And they are available 24/7, assuming there aren't any other interruptions, external interruptions on our website. They cover basic query, data visualization, how do you export the data, and we didn't have confidence intervals in the beginning, but then there was a request for that. So we have now confidence intervals. You can also combine, or what we call pool the data, and to alert, and the confidence intervals will alert if an estimate, the user is statistically stable or not. We have a dashboard so that we kind of stood up in early, soon after the lockdown orders in 2020. And so we implemented questions on COVID-19 mid-2020. And then with that, we, for the first time ever, we released preliminary estimates. Usually for those of you who join us every year, we're talking about 2022 data. So it's about, it takes about 9 months to process. So we collect the data in 2022, but then about 9 months to process the data and have this ready for you about October, which is October is today, of the next year. But for the first time, because of the demand for the data on COVID, we were able to stand up these dashboards in the same year that the data was collected. So also, I think we'll put some links here on how to access these data on COVID. These are the health profiles I spoke of. If in case you don't want to go into these web-based information scraping systems, you still have to come to our website, but you can download a PDF of some of the race and ethnicity health profiles for adults. And so this is an example of how it looks. And I see Tiffany is at the ready already, way before me, putting the URL to access these health profiles. And I think we are at the close. I'm sorry that we only have 5 minutes, but I want to thank everyone in the CHIS team for all your work. And with that, let's go to Q&A.
Thank you so much. Hi, everyone. My name is Tiffany Lopes, and I'm the Director of Communications here at the Center. I'll be going through some of the audience questions today. So first question, it's so informative to see how these health issues vary by factors like race and ethnicity, income, and education. Are there measures in CHIS that get at other social determinants of health?
So the social drivers of health are so important to ensure population health and population health equity, and the education, income, occupation is included, the neighborhood that you're at. So we do have that information. I think that kind of related to another question, so I'm going to do this very quickly. Somebody asked, why don't you use ADI and SVI data sets, which ADI is area deprivation index and SVI is social vulnerability index. So those are actually not data sets, but they're data sets of a multidimensional measure which gets at employment. Some of it also can get at green space, for example. But you can construct a measure if you'd like. And in fact, those two measures are in our Ask CHIS Neighborhood Edition if you wanted to use those measures. So there are a number of variables on social determinants or social drivers of health. And I believe I think Royce may have also put a link on some of the variables that we have.
Thank you. There's also a similar question on, is there data for Native Hawaiian, Pacific Islander, and Native/Indigenous communities?
Yeah, thank you for that question. We collect data on race that includes Native Hawaiians and Pacific Islanders. We also, so Indigenous to the Americas is following the federal standards. A respondent could identify as American Indian, Alaska Native, which we have. We also have country of birth information. So, and parents' country of birth. So for those of you who are advocates or researchers that care about advancing the health of Indigenous communities, I think that there are enough questions and variables in CHIS to identify those communities. Of course, because the population representation in a probability-based sample limits then the numbers. I think when I showed the slide on the numbers for American Indian, Alaska Natives, as well as Native Hawaiians and Pacific Islanders, for a one-year sample, it may not be enough for statistical reliability, but you can combine multiple years of data to stabilize statistically those samples. And we have actually some insights on those populations in previous fact sheets that we've had at the center.
Thank you. Todd, this question's for you. Very interesting data on mental health and issues accessing mental health care. Are there plans to explore these topics in more depth?
Yes, thank you for the question. And yes, there are plans to do further analyses with various policy briefs and fact sheets. The mental health questions in the CHIS are funded through the Department of Healthcare Services Community Services Division. And they also fund us to do some in-depth analysis on this. We have a number of policy briefs planned for the next couple of years. Topics may include further examination on topics like immigrant mental health, ACEs and mental health, adverse childhood experiences, I should clarify, housing precarity, American Indian, Alaska Native mental health, and LGBT mental health as well. So there's more to come on those. Stay tuned in the coming couple of years.
Apologies, it looks like my internet cut out.
Yeah,
I'm a little frozen, but I'm here on the other one. The last question that we have, Sean, it just disappeared.
I think it was about the correlation.
Yeah,
you got it, Sean? Okay.
Yeah, I saw the question, and thank you for that question. We didn't see significant differences between those who reported using telehealth and those that didn't report using telehealth in the past year in terms of their ability to get appointments within 2 days. But one of the interesting findings that we see on the 2022 CHIS is that those who did not receive telehealth or reported not receiving telehealth in the past year had reported foregoing needed medical care more. So there is, areas for exploration still in terms of the potential of telehealth in order to provide greater access to Californians, especially now in 2022.
Thanks so much, Sean. So it looks like we're a minute past time, so we're going to close the session. Again, thank you everyone for attending and have a great rest of the day.
Thank you.